Good morning, everyone. We're going to give it a couple minutes as people join us this morning for our latest edition of the CMT Talking Transit, the intersection of transit access and public health. So we will get started in about a minute or so, and thank you all for joining us. Good morning. On behalf of Citizens for Modern Transit, I'd like to welcome you all to the latest Talking Transit discussion on the intersection of transit access and public health, which will include important insights from Minneapolis, Baltimore, and Charlotte this morning. Before we begin the discussion, though, please join me in welcoming the CMT board members who are online with us today. Thank you for your support and commitment to transit in the St. Louis region. This year, CMT is celebrating 40 years of transit advocacy, and I'd like to take a moment and thank our 40th anniversary sponsors, including our gold sponsor, the St. Clair County Transit District, our silver sponsors, Bi-State Development, Siemens, H&TB, and Greater St. Louis, Inc., our bronze sponsors, Ameren, Missouri, St. Louis Community College, Commerce Bank, BJC Healthcare, and Enterprise Holdings. We would not be able to offer events like this without their support. So thank you very much. Also, thank you to everyone who has joined us this morning for this really important conversation on just one more benefit of public transit, the impact on public health in our communities. Research is showing access to reliable transportation is vital for public health. This conversation in the St. Louis region could not be more timely as we look towards the proposed future expansion of light rail with the Green Line. We have potentially an opportunity to improve health impacts through better accessibility to healthcare, healthy food, education, and jobs. Our panel today will feature transportation advocates and health professionals, as well as urban planning researchers. Our panel includes Megan Latshaw, with the Associate Teaching Professor at Johns Hopkins Bloomberg School of Public Health, Samuel Jordan, President of the Baltimore Transit Equity Coalition, Laura Barry Smith, Senior Research Associate at the Urban Institute, and Jason Lawrence, the Chief Transit Planning Officer at Charlotte Area Transit Systems. Welcome to all of you, and thank you for joining us. Again, if we were in person, there would be a definitive round of applause. So thank you all for joining us this morning. We are definitely going to leave time at the end for questions and comments, but please feel free to put those in the chat or the Q&A boxes as we move through our conversation this morning. Each panelist is going to provide about a 10-minute overview on the 3 case studies that we have before us. Again, Baltimore, Minneapolis, and Charlotte. So let's jump right in with the city of Baltimore with Professor Megan Latshaw and with Johns Hopkins and Samuel Jordan, the president of the Baltimore Transit Equity Coalition. Welcome.
And thank you so much. Good morning to each of you, and good morning to our other listeners and participants in the audience and in the webinar. Very glad to have this opportunity to speak about Baltimore. And I'm welcoming you from sacred land of indigenous people. And that screenshot you see of me, that's Baltimore Harbor. That is real smog. And that smog we might talk about at some point, but our mapping project that we'll discuss has actually identified that as one of the areas needing urgent investments in the abatement of pollution and the review and examination of the adverse impacts that it has caused. But I want to step back and give you just a bit of our origin story. The Baltimore Transit Equity Coalition was organized within hours of Governor Larry Hogan's cancellation of the Red Line Light Rail project. That was for us a demonstration of the operation of race-based transit policy, structural racism in public transportation. We see that all over the nation. We could certainly discuss it further, But you can imagine that in public transit systems all over the nation, there are inequalities, there are disparities. There are serious issues with respect to racialization of public transportation, as with all areas of public policy, there might be a racial differential. But in our case, in Baltimore, you might have seen in the news that we're also, it seems like not only an infrastructure epicenter, but multiple crises in uh, issues with respect to budget, which is not uncommon around the nation, but also the most recent collapse of the Francis Scott Key Bridge. And so we're addressing issues converging at the same time, but we've always kept alive this notion of the value of the completion of the Red Line Light Rail project and its significance for uh, communities of color, uh, households with modest incomes. But what it has also led us to do is to examine the intersectionalities of transit with healthcare, education, employment, excuse me. And what we have found is that it is absolutely necessary for us to develop those linkages because there's a sort of interdependence on the attention we give to any of those issues in the intersectionality that also uh, promote benefits or at least insights into the central issue for us, of course, which has been transit, but addressing the way it impacts the lives of riders and those who are not necessarily riders, but residents in the region. And what we want to emphasize is in the origin study, we began with an examination and participation in the Transit and Climate Initiative. That was an attempt to develop a credit approach for pollutions. That is, pollutants would pay into a pool of funds that would then be used for online and fence lines communities to resolve certain problems, but also to abate pollution. As you know, the transportation sector generates at least 40% of the harmful emissions. And in the study with Johns Hopkins was a result of my having participated with Dr. Latschow in her classes in a service learning program, but it also gave us the occasion to develop a strategy for detecting the communities most in need of urgent investments and abatement of pollution, but it also showed at least the adverse impacts, health impacts of the pollutants, the intersection of transit equity, and what we call social vulnerable indicators and social vulnerability indicators. And when those maps are overlaid, we can see now what we are explaining to policymakers are the areas that are in urgent need of investment. Now, I would add that in addition to being able to identify the communities that are in need, we think it's more important or just as important to engage with those communities in developing a process from identification to assessment of the damage that may have been done, then engaging with the communities to design sustainable intervention, and finally, of course, addressing this issue with policymakers and the legislation and the governor's office to see if we can find funds to make the kind of improvements or at least address the adverse impacts while we are addressing the question of transit equity. So we're keeping these, they're simultaneously being developed, but I would think that it's important for those who are addressing this issue of transit and health that we are attempting, for example, to make sure there's a linkage that we have developed and shared with the communities, the defense against climate change, the defense against additional environmental destruction. And we captured that first in a publication that Dr. Lasher, I'm sure, will discuss further, but entitled Transit Equity, Environmental Health, Transit Equity and Environmental Health in Baltimore City. was published and released in September of 2021 to good reviews, but it provides a map, a roadmap to share with policymakers, and that for all advocates on this intersectionality of transit and the environment, for example, will find this is a great deal of difficulty in some instances, but a lot of work needs to be done with the policymakers to have many who can help solve these issues understand the gravity that we are at a crossroads when we address these intersectionalities. But with respect to our work, for example, in completing the Red Line Light Rail project that was canceled by the governor, we are in a, Baltimore has become a classroom in which we are trying to share with as many of the regional residents, leaders, community associations, uh, those who are sensitive and studying this question, that we can develop an ongoing approach to abating the impacts of pollution and addressing the health impacts, the adverse health impacts, while we are providing an important improvement in a public service. And bringing them along at the same time is not herding cats, but it's actually looking at and learning the interconnections and developing them apace with the kind of support that we're hoping we can get from this administration under Governor Wes Moore to abandon the policies of the former governor, Larry Hogan, whose Department of Transportation did not address these questions. So I would say that at once, and before turning it over to Dr. Latshaw, that we are trying to proceed with a knowledge-based improvement and development in Baltimore, rather than fear-mongering, as sometimes is used when talking about changes in the environment or facing the challenges of climate change. That is, we can determine where we need to apply remedies, solutions, and investments with the support and engagements of the communities most directly affected. We address issues not only with housing, health, education, employment, food security, but it becomes clear that transit is at the nexus of these intersectionalities. And that's where the most important, I think, elements at the moment of our investment strategies are targeting. I'm sure there are questions about what this means for us in the long term, but legislative policies must be pursued before we have clear directions and addressing solutions to these problems with codification, so that we have at least shifted some of the power with respect to the ability of communities most directly affected to affect the changes that are important to them and necessary to them and their households. I want to stop there, and perhaps Dr. Latshaw will continue, and the two of us, I'm sure, can answer some questions.
Great. Thank you so much, Samuel. So I'm going to share some slides with folks to give them a little bit more history and context. So this is a map that a lot of people in Baltimore are familiar with. Baltimore was one of the first cities to do this thing called redlining, which made it illegal to give mortgages to people based on race or religion in Baltimore. And so in the red areas is where a lot of red and then blue and yellow areas are sort of, well, actually the red and yellow areas are where Blacks were allowed to live. And then the The green areas are where it was mostly whites who were able to live. And this is from 1937. The Homeowners Loan Corporation, which was a semi-governmental agency, had in writing who was allowed to be given mortgage loans and who was not. So take a look at the pattern. You'll start to see what we call in Baltimore the black butterfly and the white owl. So um, this, I'm going to skip through the next couple of, because I'm just reusing this slide. But I will say, I will just give you the main message of this slide. This basically systematic racism, racism in general has negative effects on health, right? And so when we look at health today, we still see evidence of this black butterfly and white owl. So, in the bright red, you'll see life expectancy in those neighborhoods is less than 67 years, whereas in the dark blue neighborhoods, life expectancy is over 82 years. So if you look at, say, the area, let me see if I can get my pointer. The area like with the two dark blue, that's called Roland Park. And if you go a little bit further down, less than 5 miles away, it's Seton Hill. And this is less than 5 miles, and it has a 20-year difference in life expectancy. So these historic policies are still impacting life today in Baltimore. And so one of the things that this red line that Mr. Jordan mentioned, what it was going to do, it was going to connect East and West Baltimore. And if you grew up in Baltimore, people will tell you that if they grew up on the East Side, they may never have actually been over to the West Side and vice versa. Baltimore is definitely a city of neighborhoods, and some people never really venture outside their neighborhood. And so the red line was really supposed to be this amazing connector that would connect the two sides of the city, especially to jobs. There's a lot of jobs that have cropped up over time along the east side of Baltimore. There's Hopkins Bayview, which employs a lot of people. There's Trade Point Atlantic, Amazon warehouses, and things like that. And so this red line was going to lead to a lot of transit-oriented development and better access to schools and healthcare and jobs. And we got all this money from the federal government to do it, hundreds of millions of dollars, and the governor decided to cancel this and send all that money back to the federal government. And then the money that the state had set aside, he basically took that money and widened highways on our eastern shore, which is a mostly white area. So this disappointed a lot of people and was the genesis of Mr. Jordan's organization. And so fast forward to around 2016, I met Mr. Jordan at an environmental justice conference. And I don't know if you remember this, Mr. Jordan, but for the first 5 minutes after you found out I worked at Hopkins, you kind of told me all the things that Hopkins was doing wrong when it came to transit. And at first I was a little defensive inside my head, but after a while, I realized, yeah, Mr. Jordan's right. Hopkins can do a lot better when it comes to transit. But at that point in my career, I was a new faculty member. And I said to him, like, you're absolutely right. I don't know what I can do to help you. I can't change Hopkins policies. I said, but I can maybe collect some data. And he said, great, let's do it. And so really no idea what I was doing, but we worked through it and we put together this amazing motley crew of a team, and we developed this report. And there's a accompanying video that you're seeing here. There's the website where if you want to watch the video, it's only 2 minutes, and download the report. You can do it at bit.ly/Baltimore Transit Equity. Here's what we found. Mr. Jordan said, I want you to make me 4 maps. He said, the first map, I want it to be related to transit access. Who lives near, like how many stops are near different census tracts? And what is the average commute time if you take public transit? What's the average commute time if you drive compared to if you take public transit? So we looked at 6 different indicators of transit access, and then we combined all those indicators into this larger map along the left. And so you can kind of see a little bit of that black butterfly and white L. So the white L kind of goes down the middle and across. And so even today, we're still seeing the effects of those racist policies that we talked about at the beginning. The second map Mr. Jordan wanted us to make was on social vulnerability. And so for this, we used the CDC, the Centers for Disease Control and Prevention. They have what's called the Social Vulnerability Index. And there's four main pieces of that index: minority language and minority status and language, socioeconomic status, housing type and transportation, and then household composition and disability. And again, we put all these indicators into a main map that sort of measured or tried to get at this sense of social vulnerability. Who are the people in the city who are most vulnerable to environmental exposures, or to losing access to transit, or to health effects? And again, you see that white L and the black butterfly. The third map that Mr. Jordan asked for was air pollution. He started off by talking about smog. I'm looking out my window where the old bridge used to be. I used to have a view of the bridge. It's very sad, but it still looks smoggy today. So the third map was air pollution. You can see this map looks very different, and that's because there's only 3 EPA monitors in the Baltimore region. And so the data that we can model based on those 3 monitors doesn't really give you a lot of nuance. So that's why this map is kind of general. You can see we looked at different air pollution indicators like particulate matter, ozone, traffic proximity. And you can see around the harbor, it really lit up as being the most polluted areas, which makes sense. There's a lot of traffic, both car and at one point there was a lot of boat traffic there too. Hopefully we'll get back to that soon. And then the last set of maps that he wanted us to create were health maps. And you can see we had 6 different health indicators that are related to either transit or air pollution related to transit. And those were asthma, COPD, lung cancer, COVID-19 heart disease, and low birth weight. Again, you kind of see that white L and black butterfly, maybe not as clearly as in other cases. But what we did at the end of the day was we put all 4 maps together. So we put transit access, social vulnerability, air pollution, and health into a single map. And there were a bunch of areas that lit up as bright red. And those were the areas that we said this needs investment in transit. And so we started reaching out to those neighborhoods. We shared this report with the state legislature. And actually, the state legislature passed last year the Transportation Equity Act of 2023, which requires the Maryland Transit Administration to perform an equity analysis before making any major transit changes, sort of like what we did here, as well as a cost-benefit analysis, and to have meetings with affected communities. We submitted our draft report to the U.S. Department of Transportation. They had asked for a public comment about how to measure transit equity, and we said, well, this is how we did it. And it was really neat because they developed this tool to measure transit equity. Did somebody say something? And this tool kind of looks very similar to what we did. It looks at environmental risk and environmental burden. It looks at vulnerability, both health and social vulnerability, and it looks at transportation insecurity. So it's pretty neat to think that this motley crew of a team, where we didn't really quite know exactly what we were doing, was able to influence state-based legislation as well as U.S. Department of Transportation policies and programs. And I mentioned this motley crew of a team. These are all the people that assisted us throughout the project, a lot of them students, and we're really grateful for that. So I think that is my last slide. So I'm going to stop sharing.
Thank you, Megan and
Mhm.
Mr. Jordan. I think that's really great information as we turn to Jason. And I think one of the things that Mr. Jordan said that's really important is building this knowledge base. In Missouri, We're represented on this call from cities like Springfield and Kansas City and St. Louis, and many are looking not only at a major investment corridor like in St. Louis, the Green Line, but many are looking at increased frequency, which can also have a significant impact on this access and equity. And so I think that this is a really good conversation to start with. Now we're going to turn it over to Jason. Jason is from the transit agency perspective. So Jason is the Chief Planning Officer at Charlotte Area Transit Systems. And so Jason, welcome, and we're going to turn it over to you to talk a little bit about the Charlotte story.
Great, excellent, thank you. And so much of what you already have seen, there's going to be some kind of similarities in some of the work that we do, but also how we're applying some of these things that, once you know these things, once you know about redlining, once you know about all this stuff that's happened in the past, I think it's the responsibility of planners to fold that into how we think about things, because it was probably urban planners and transportation engineers that did it originally and was very intentional. And so we at CATS are certainly folding what you're seeing here today into how we're thinking about our future projects, how we're thinking about how we roll out services. And so what I want to talk a little bit about today is, from us, give a little bit of background about CATS and who we are, kind of give the transit agency perspective, how we set our vision, how we implemented our projects and services, those results, and how we're looking to move forward. A couple of quick stats about us as an agency. We are a department of the city of Charlotte. We're not an independent authority. However, we are funded from the county, Mecklenburg County, with a 0.5-cent sales tax. We serve a population of around 1.3 million. And you can see there our numbers in square miles and number of vehicles. And we are a bus, rail, and paratransit, so human services type of service. So we do all the full suite of mobility services across Mecklenburg County. And being, part of the city of Charlotte helps us really work very closely with our major jurisdiction within our service area. And so we work very closely with their DOT as they look to build housing, how they look to equate jobs with mobility. And so we're working very closely with them, because at the end of the day, from a transit perspective, we need to move people, and that can be may physically move people, but also move people socioeconomically to opportunity. And it's not just, as we think about mobility, it's not just the trains and the buses, but all the things that connect us together. These things aren't islands. And so a transportation plan is a land use plan. A land use plan is a transportation plan. You cannot separate the two. And so I think in our history, we have tried to do that, and we see what the impacts are to land use and to people's lives each and every day. And so we certainly see that here, that an integrated approach is transit and land use together. And integrating, now we think about also kind of the active uses, and this gets to the health discussion, active uses around our transit, like rail trails and things like that you see in the photos here. But it did start out as a vision for us in the mid-90s. We had a conversation about how we were growing, and it wasn't if we were able to grow, it was like how we were going to grow. And so we had a dialogue around transit and land use. We packaged that to a bond referendum in 1998 with roads, as well as a 0.5-cent sales tax, and that was adopted. We're having additional conversations soon to fund our capital and operating programs for the next 20 years. But that 0.5-cent sales tax has funded everything that we have on the ground today. But that growth was much more than we had anticipated. This is actually, those of you who are older than not 23 years old yet, we had PowerPoint in the 90s, and these are actual slides from the 90s. So that graphic there was from the 1990s, where we anticipated that the county would be almost 1 million people by 2025. Well, we hit that in 2014. And so our growth is much more than anticipated across our jurisdictions and across our county. And then today, we've adapted that plan into 2 guiding documents, a rail system plan called our 2030 Transit System Plan, 5 corridors with light rail, streetcar, and commuter rail, as well as some bus rapid transit. And we also have a system plan for our bus side of high frequency bus routes, mobility hubs, and microtransit on-demand zones. We took a system level approach to our bus service to put that in front of our board to adopt strategies on how to improve bus service, because a transit system is only as successful as a high frequent quality bus network. The 2 have to work together. And we are continuing to advance our plan. We have one light rail project in place, and we are advancing multiple other light rail projects and commuter rail projects and streetcar projects across our community. Today, I'll focus a little bit more on the Lynx Blue Line because that's where we definitely have seen some health research put in place. It opened in 2 phases, 2007 and 2018, and it's just under 19 miles, 26 stations across Mecklenburg County. And the growth on that corridor has been amazing. From just before the Blue Line opened, this is a screenshot, 2007 before the original opened, and then and this is, within 15 years, this is 2023, but the whole area grew up around it. The area has matured from kind of an industrial area to now like an office complex area. So very, very short order, the place changed very quickly. And you can see here the numbers. This is not tax dollars. This is actual just economic development, cost of construction. And so just under $9 billion worth of private investment, primarily concentrated within about 4 miles of the project. So not along the whole corridor. And then in 2010, there was a study that was published in the American Journal of Preventive Medicine that looked at what is some of the health benefits, some of the things that maybe we weren't thinking about. And what was discovered that, those individuals that used the Blue Line to commute, that lived along the corridor, had a lower body mass index than those that were not along that corridor. And I think that you see that in many cities, that the more you walk, the more health that is available to you. And so we're also, folding that into how we think about our transit-oriented development. We have policies in place to entice transit-oriented development, not only for our existing projects, but also for our future projects. And the rail trails that are built with our past projects, we now do that at the beginning of our projects. So rail trail, TOD studies are all done at the very beginning of our projects now. So we folded that learning back into how we advance the rest of our capital program. So, but that's the rail side. That's the capital piece that we've been very successful at. But one thing, when it comes to the bus side, like how do we truly improve the quality of life of individuals to have access to healthcare, education, and opportunity? And I don't know if we're all familiar with it, what's called often referred to as the Chetty study. It was Harvard's University 2015 report, The Impact of Neighborhoods on Intergenerational Mobility. That study has since been updated. But Charlotte did not fare well in that study. We were 50 out of 50 of major metropolitan areas of people's ability to move up socioeconomically. If you were born poor in a zip code, you were likely to die poor in a zip code. And so, but if you boil down all the factors in that study, the thing that was the clearest indicator of how a person moves up is travel time. And the ability to have frequent transit, to have easy transfer across the city is something that we have a big role to play in. And so if we go back to like our system planning, as we look at our system level approach to service, we have to adapt for bus service. We need to think differently about bus service instead of thinking about hub and spoke, coming into a main downtown terminal and then going out to your jobs. We feel that we need more transit investment around hubs, around ease of transfer, to have what's called microtransit, more on-demand transit that connects people into high-frequency transit. Maybe, always we'll need more service in the peak, but we need more service in the midday and the nights and the weekends. If we only focus on the peak, we're focusing on people who go to 9-to-5 jobs, who go to office work. That is not the majority of people use our transit every single day. People's schedules have shifted. People are doing scheduled work or shift work. Peak hour service doesn't fit that. So we need all day more high frequency service. And then ultimately bus stops. If you're in any transit system, bus stops are the bane of our existence. We need more investment in bus stops. And we've certainly taken that to heart and taken an equity-based approach to prioritize where we need to put bus stops. And these are some of the worst case scenarios, but bus stops truly are the transit's front door. It's what people see throughout a community. Some really good, bad examples of what we have here in some of our community. Prior to our adoption of a system level plan towards bus stops, towards bus service, we had a ridership based approach. If you had a certain number of boardings or a certain number of activity, you would get a shelter or a bench. There wasn't a lot of leeway there. And so, but if it's a high ridership stop, it's likely to have high frequency. High frequency means people are waiting less. So in some ways, some people who wait longer need more shelter from the shade, from the heat. And so we turned our prioritization approach on its head and came up with a new way to to prioritize bus stop investment. And so we took ridership, but we put point scores. Was it along one of our priority corridors? How long does somebody have to wait? Is it typically a transfer location? Let's look at the equity population around. What are the demographics? Are there people there that need service? Also, is it near a hospital? Is it affordable housing? All these other factors to put in play. We gave every single bus stop a score, and then we used our American with Disabilities transition plan to prioritize the most serious stops. And so we now, from 0 to 3,000, every bus stop has a score, and we're taking them batches at a time. Instead of focusing just on ridership, we're focusing on a capital plan to improve our bus stops. And we have some good examples of bus stops too. So this is what we're going towards. We have a number of bus stops that are great in our community, and we're working to improve those, and also taking other approach to engage with the community, like placemaking grants and working with communities to beautify and do adopt a stop. So we're looking at different ways to focus on bus stops, is really just being very intentional about that from a programmatic standpoint, because ultimately it is about the customer experience. If we want people to get to transit, as we fold these learnings about equity and what we've seen for mudlining in communities, that there's a trust that needs to be built as we as public officials go out. And that also comes from the customer experience, and turning our community engagement into not being totally transactional, because often transactions are, we need something, tell us what you think about this plan. Let's go out and just get a thermometer check on where people are. So we're doing a lot of focus on customer experience on the things that you see on the slide there. So I'll close out with two other things that I also don't think we don't talk about enough in the community, and particularly as it comes to healthcare, is paratransit service. And so just a shout out to the people who do this each and every day, who take people to doctor's appointments, people who can't go to transit, and enable people to age in place over time. So mobility is not just the bus and the rail, but it's also the human services that we do each and every day. And as an older father who has young children now, I do want to, my daughter's not old enough to be embarrassed by photos yet, and I'm having another child in a week and a half, so I'll swap him out here eventually. But I do think, as we think about transit, the large majority of people are on either ends of the spectrum. They're too young to drive, or they're too old to drive, or they're not able to drive. But also, as you go through life and the dignity of travel, what will be our phase of life at different points in our life? And how do we introduce dignity in how a person travels throughout our community? Because to be successful, we have to plan and build more inclusive and thoughtful infrastructure from day one. And that's something we're taking to heart. But all layers of mobility have to advance, not just the rail, the big high capital projects, but also the day-to-day bus service, and how we think about services, that access to opportunity to move up. We don't like being 50 out of 50. We want our community to have opportunities, and transit has a big piece of that. And with that, that's my last slide, and I'll pass it on to Laura or Kim to introduce the next speaker. Thank you.
Thank you, Jason. Thank you so much. What's interesting is in St. Louis, one of our biggest partners is AARP. They have more than 3,000 constituents in the St. Louis area. And so some of the things that you just touched on, Jason, are conversations we're having on a daily basis, with the fact that we do have an aging population and they want to age in place. And so whether it's programming or addressing the bus stops or addressing paratransit, it does have to have this holistic view of mobility in order to ensure that people can still access their community, and there's a health benefit to that, so it's all wrapped together. So thank you for that, and the conversation that we just had about Charlotte. Now let's change the city that we're looking at, and let's turn it over to Laura Berry-Smith. She is the Senior Research Associate with the Urban Institute, and she's going to talk a little bit about her work in Minneapolis on the Green Line. Fitting name as we have that conversation in St. Louis, Laura. So we're going to turn it over to you.
All right, thanks so much. And thanks for having me here today. As Kim said, my name's Laura. I'm a Senior Research Associate in the Health Policy Center at the Urban Institute, which is a Washington, D.C. based social and economic policy research organization. I myself am based in Minneapolis. My training is in health economics, and I do lots of quantitative research in the health policy space, mostly focused on actually the Medicare and Medicaid health insurance programs. But recently, some of my work has started to focus on the relationship between transportation and access to care, which is an area I'm hoping to continue to work more in. And I'm going to be talking about two studies today. And the first one is actually looking at a nationally representative data. So I'll start there, and we can go to the next slide, please. I do want to acknowledge the Robert Wood Johnson Foundation, whose funding has supported a lot of our work, and also my colleagues at the Urban Institute and the University of Minnesota, who are listed here. Next slide. So about 1 year ago, we published a research brief on the Urban Institute webpage that documented the extent of transportation barriers to healthcare in the US. And this caught a lot of media attention. So in this research, we conducted a nationally representative survey reaching over 9,000 adults across the country. And this is a survey that we field regularly, typically to ask about many different things related to people's healthcare coverage and access to healthcare. But on this wave of it, we added a series of questions specifically about people's access to a vehicle in their household, their self-perceived access to public transportation and ability to get around without a car, and whether or not they experience transportation barriers to receiving healthcare. We then analyze this survey data to understand these patterns both overall as well as how they varied by various socio-demographic characteristics. Next slide, please. So this slide summarizes some of our main findings. So this chart tells us the share of adults ages 18 to 64 who reported that they had to forego needed health care sometime in the past year because of difficulty finding transportation. So the very top bar tells us that overall 5% of adults reported this experience. However, there were differences in this experience by various characteristics. So specifically, we see that Black and Hispanic adults, adults with lower incomes, adults with disabilities, adults with public health insurance coverage, and adults who did not have access to a vehicle were significantly more likely to have had transportation barriers to healthcare, very clearly showing that there is inequity in who is most at risk for missing doctor's appointments because of transportation. So given that transportation barriers were much more common among adults without a vehicle, we then further focused our analysis on these adults without a vehicle and examined how their access to public transportation was associated with their access to healthcare. So next slide, please. So what we found is that among adults without household access to a vehicle, their ability to get around without a car and their neighborhood access to public transportation are both really important for accessing healthcare. So the very bottom bar tells us that 21%, or more than 1 in 5 adults with no vehicle and with fair or poor access to public transit had to forego needed healthcare because of transportation barriers. So the study has many great strengths. It gathered data from a nationally representative survey, was able to capture people's subjective experiences with transportation barriers to healthcare. And in that way, I think it contributes important evidence on the importance of transportation and healthcare. Next slide, please. So it's clear, not only from our work, but lots of other studies and knowledge, that adequate transportation is really important for access to healthcare. But there's actually very little published empirical evidence documenting a clear causal link between the two. And it's really important to have this type of evidence. For example, it's easy to imagine that people who do not have great access to public transit may also face other difficulties in accessing healthcare, things that can be difficult to control for, such as costs of healthcare, lack of insurance, difficulty taking time off work, lack of availability of providers, the list could go on. So the possibility of these other confounding factors partially explaining the relationship that we observe between access to public transit and healthcare is why I also want to talk today about another study I led, in which we used a more rigorous research design and a very different type of data to actually evaluate the effects of a public transit expansion on access to healthcare. And this is where we are focused in the Minneapolis area. So the context for this study is that in 2014, a new light rail line known as the Green Line opened in the Twin Cities of Minneapolis-St. Paul. This new line connected the main business districts of Minneapolis and St. Paul and ran through many of the metro area's lowest income neighborhoods. It also ran near several healthcare clinics affiliated with one of the largest healthcare systems in the Twin Cities. Next slide, please. So to study the impact of this new green line on access to healthcare, we put together a huge data set from an electronic health record system, which included records of all appointments that were scheduled at this large health system that I mentioned. So the really cool thing about this data set is that we were able to see for all appointments that were scheduled, whether they were completed as scheduled or whether they resulted in a patient not showing up or a no-show. Altogether, this data set represented over 3.5 million scheduled appointments at 97 different healthcare clinics in the area across a 4-year time period, including 2 years before and 2 years after the light rail opened. We then used an econometric strategy to test whether the opening of the green line led to a decrease in no-shows. And to do this, we compared no-show rates before and after the line opened for people living close to the new line compared to people not living close to the new line. And so this is a research design known as difference in differences. And the advantage of this research design is that by comparing changes in no-show visits over time among a group of people who we expect to most directly benefit from the new light rail line compared to a group of people who we do not expect to benefit from the new light rail line, we're effectively controlling for both sort of underlying trends over time in no-show visits and also for other differences between these two groups of people that may cause them to have different no-show rates. So in essence, we're controlling for those confounding factors that I was listing off a minute ago and isolating the impact of the new light rail line itself on the probability of people missing their appointments. Next slide, please. So the results of this analysis showed that there was a statistically significant drop in no-show visits after the green line opened for people living near the new green line relative to people not living near it. And importantly, the effects of the light rail opening were largest for people covered by Medicaid health insurance. So Medicaid is a program that primarily covers people with low incomes. And for people with Medicaid coverage, no-shows declined by 8.6% after the light rail opened. And then one other thing we looked at in addition to no-shows was the frequency of same-day visits or visits where people essentially just showed up to the office. And we actually found an increase in same-day visits. So yet another indication that the opening of the light rail line facilitated access to healthcare. Next slide. So just to kind of summarize and wrap up, this study provides empirical evidence using a quasi-experimental research design showing that expanding a public transit system improved access to healthcare, and especially for people with Medicaid health insurance coverage, who again are primarily people with low incomes and disproportionately are people of color. So this really underscores that robust public transit systems can promote equity in access to healthcare. Of course, fewer missed doctor's appointments likely means fewer delays in the diagnosis or treatment of health conditions, but more research would be needed to really clearly document the causal impacts of public transit on longer-term health outcomes themselves. And then finally, one of the study's unique strengths was its use of a very large multi-year data set representing over 3 million patients. But in this study, we were not able to talk to people about their experiences using the light rail or to learn what barriers they might have continued to face, such as cost barriers or a lack of the line not stopping frequently enough, which is why both quantitative studies like this one and studies that capture people's actual day-to-day experiences are both really important types of evidence to have. Next slide, I think it's just a wrap-up slide. Yeah, so I can wrap it up and pass it back, but thank you all, and my contact info is here if anyone would like to connect.
Thank you, Laura, so much. I just want to reiterate her top bullet point from her presentation that there is empirical data that shows investment in public transit improves access to healthcare and overall health. So, you know, I read your slide deck before we started this, and I said to my colleagues, I was like, That's the key takeaway right there. Empirical data proving that access to public health care improves public health. So thank you very much. That was a great presentation. The first question that we've had was, is your presentation available, Laura? So we'd like to post it on our website after, if you're all willing to let us do that. And it will be a resource for others. So thank you very much. So I think all of these case studies really underscore just how critical transit access is to the health of our community. So now let's jump in. We have about 12 to 15 minutes with some questions on each of the areas or other information that participants would like to hear. So from your experiences, our first question, from your experiences, what is the key message here for a city like St. Louis, our elected officials, our stakeholders, our residents, on individuals who are being asked to potentially support a 5.8-mile light rail capital expansion project? What are the key message from each of your cities that you think would be a takeaway for St. Louis based on that, based on what you've just reported today?
I think I tried maybe a couple of comments on our experience. One is that we have found that reliability in transit is the more important metric or factor in its usefulness. And what we had, I think this is tracked in Laura's comments, that when there's an expected unreliability, it also introduces a great deal of uncertainty about the, for example, riders who are transit reliant are dependent upon a transit system that guarantees them precarious employment, low wages, high turnover. Again, that impacts their abilities to support themselves and their families, but it also introduces a kind of factor that leads to this appointments being dropped, appointments that can't be kept. And this, I think, goes in with Laura's help, transit, and her presentation. But we also have seen that when there is a greater knowledge base, that is the knowledge base I was speaking of, we've appointed an EJ organizer whose job is to make certain that the communities along the corridor, this might be helpful, Kim, in St. Louis, that the persons along the corridor do know that they have a role and can have an impact, can be agents of improved health in the space of environmental destruction and climate change. This answers a question. So many of the members of those households and leaders of those communities had no concept that they themselves could make an impact on climate change, on environmental destruction. And our EJ organizer's job is to help develop a knowledge base that actually produces results. There's a lot of discussion about climate and health, of course, and the intersectionality, but not a lot of that information gets to the communities that's in a form that can be used, that leads to action in which they are engaged actively.
Thank you. Did anyone else want to weigh in on that question?
I would just say, and not knowing the situation completely, but I do think our experience has been that land use is a big piece of this puzzle, and not, work well with whatever partners you need to, work with the development community, but don't forget about affordable housing. I think that's something we did not do with our first project. I think we weren't fully prepared for how much infill development we would get for multifamily. And much of the original project is not affordable. And we've learned from that mistake to include policies that allow for extra density if affordable housing is put in place, or to buy into a housing trust fund. And so I think there is, just the affordable housing piece is really important. And be patient. These projects take time, and they need to carry through multiple administrations to come to fruition. So have shared vision to get it to the finish line.
Quickly, we have a connection, by the way, Jason, with Charlotte, former Secretary of the Department of Transportation, Anthony Fox, former
Yep.
mayor.
That's right.
Took a great interest in development of transit projects in Baltimore. He was actually a supporter, active supporter of our completion of the Red Line Light Rail project, and was quite disappointed and expressed it when it was canceled. But what we have gotten from it, once we do insist, as you do, that transit policy and land use policy should never be torn asunder. At the same time, Baltimore is, as so many others, I believe, Minneapolis, Charlotte, perhaps, but St. Louis, there are a number of highways to nowhere. In Maryland, major and highly, in fact, notorious highway to nowhere, where the interstate highway system had been used, or at least weaponized, against communities of color, particularly Black communities, over a long period of time, in fact, continues today. But what it means for us is that we are now addressing it, and it means assembling these issues of intersectionality, affordable housing, of course, healthcare and access to healthcare, education, employment are all impacted. But this is a way that we're saying that we can make, we can deal with the past. When the highways to nowhere meant that targeted communities, targeted because of race, were certainly underserved, underrepresented, and had little resources or few resources. Now we're saying that this approach should be addressed nationally in a number of communities that we impact with, that we intersect with.
Thank you, Mr. Jordan. So Laura, quick question for you. Your health study of the Green Line, could you talk a little bit about how these studies have been funded in Minneapolis? Who's behind that? Was it the Robert Woods Johnson Foundation, or what was the impetus behind these studies?
Yeah, so the Minneapolis study actually I started it when I was a PhD student, and it was part of my dissertation research. So
Okay.
I through my funding at the university, which came from a variety of sources, I got access to the data. The data was actually available to me for free as a student, and the university's connection with the health system, my time was essentially free since I was a student. And then some of this work was continued when I was at the Urban Institute. And there, yes, a lot of my funding comes from the Robert Wood Johnson Foundation. So that helped wrap it up.
Okay, great. So, okay. And did you partner for your PhD with the transit agency, or did you do this all on your own?
We did not formally partner with them. I spoke with a few different people there throughout the course of the project. I also worked a little bit with a professor, a faculty member in the School of Public Policy, who was an expert in transit research. But there wasn't any sort of formal partnership. It's been so long now. I'm trying to remember exactly who all I spoke with. But yeah, I think that, you know, as a researcher who is sort of distanced from the day-to-day world of transit, it's really important to be collaborating across areas of expertise.
Great, thank you. So Jason, quick question for you. We have a lot of transit agency representation on our webinar today, from small agencies to larger urban area agencies. What was the impetus behind this holistic approach to public transit, this new vision at Charlotte? When did that come about, and how long have you been implementing that vision for not only capital expansion, but a little bit of what you talked about, you know, looking at the bus stops as the welcome mat to transit in your communities and frequency? So what was the impetus behind that holistic vision, and when did that start?
Sure. Yeah, so I think, you know, the whole transit land use connection, that was really from the beginning. I mean, I think that was dialogue that happened in the early 90s here in our community about the linkages between growth. There was a lot of discussions around growth at that time. Smart growth was, buzzwords, Portland's urban boundary that
Yeah.
they had put in place. All that was kind of percolating through the kind of the urban planning ether at the time. And so I think that's how it manifested here, was thinking about transit and land use and that connection. So that we kind of were founded on that, so and then working, we're in the same building as our land use planners. So I go upstairs to talk about rezonings or land development. So that was just kind of embedded within the culture here, I think, early on. And not having like a large program to begin with, we were starting from scratch. So we didn't have like a heavy operations already. We were mostly a bus system prior to that. And so I think it was just that, bringing in people that had that kind of mindset early on helped with that. And then that kind of percolated. It was a cultural thing, I think. And then also as we, take into heart, like when you see studies, you see rankings, and then just this connection between health and opportunity, and then just transit, such a big piece of that. So I think we kept an open mind to that, and then just brought people in and staff that kind of felt that way. And then it came down to leadership too. I think we've had some really strong leaders that saw that intersectionality of transit, land use, and opportunity.
Thank you, Jason. So before we wrap today, I always ask this question, and I think it's really important because we want to know from your perspective, what is the key takeaway from each of you for our audience this morning about the importance of transit access and community health? What's the key takeaway from Minneapolis, Baltimore, and Charlotte for cities in Missouri? Megan,
For
you
me, I
want to
think
jump in?
the key takeaway is transit to me is like a magic answer. It leads to development. It connects people to jobs. It connects people to education. It connects people to healthy food. It connects them to healthcare. It's like, so you can kill so many birds with one stone. So and then being at Hopkins, I feel like, I put in the chat data, right? So for as much as we can collect data for those people who may not be convinced of what we're saying, I think that's really important.
Thank you, Megan.
I can piggyback back off of that. I'm also a big believer in the importance of evidence to support policy change. And so hopefully the work presented today and all the other great research in this space, and hopefully continued and future work in this space, can serve that role in really demonstrating the positive impacts that transit can have on access to health and equity in healthcare and health.
Thank you, Laura. Jason or Samuel?
I would add something.
Go
Right ahead,
Samuel.
Jason.
Go ahead.
Yes.
Go ahead.
We're sort of lending to the environmentalist community here in Maryland some techniques we learned through the lobbying for the passage of the Transportation Equity Act of 2023. As Dr. Latchell mentioned, Megan mentioned that it includes a requirement that before a transit policy can be implemented, it must pass a prior transit equity analysis review. And if it doesn't pass, then it should not be implemented. Well, it has given us this idea that maybe we can talk with the environments and say that some of their focus can be shifted from regulatory reform to a greater study, closer study of the disproportionately adverse impacts on health, for example, on the communities. Part of that means also that we've seen that we're using the term transit reliant because we think that now we can look at those who are transit reliant as a community. They have characteristics that form a community. They have personal debt. They have anxiety about education for their children. They are late to work often. They have just lifestyles, quality of life that is greatly improved with transit quality as well. So it's a community, and I think we can find some factors that can be studied in that community and present that as well as a factor in their well-being.
Yeah, and that's a great comment, Sam. I'll just close out that at the end of the day, what we're all talking about here, and the data is important, but you need to continue to collect that. But it's like, what stories are you telling, and what's look at what you're actually being put out, and is that the right story? And then what stories do you want to tell? And you need to really think that through carefully and intentionally. And then I would say, be patient. This stuff takes time, but you got to start. We don't eat apples off the tree. We don't plant a seed and expect to eat apples off that tree. We're going to wait for that. So I think it's just being patient. Tell the stories that gets transit in the same space as water and schools and streetlights, because it's a critical piece of our public infrastructure.
Thank you. Thank you to all of our speakers today. And as an organization celebrating 40 years of transit advocacy, we've learned to be patient, even though it's not one of our, top virtues. I promise you that. So we really appreciate all of your presentations today. We will make those available on our website as a resource. I also want to thank Travis Wood in my office for helping to find all of you and put this program together. This has been a really informative program, and I think that there's some really good information that can be applied in any city, whether it's St. Louis looking at a proposed light rail expansion or some of our other communities across the state. So thank you very much. As we look into the future, we definitely have to keep in mind all the possibilities of transit. Megan touched on it a little. It can be considered magical because it can go well beyond just that ride from point A to point B. And what does transit investment look like moving into the future? So as we move forward, we hope that you will participate in the conversation around public transit. There is a lot going on right now. There are some open houses this week in the St. Louis region alone on the light rail expansion project. So make sure you attend and have your voice heard. Also, we're in Missouri. Our state legislature is looking at state investment of public transit. It's a critical piece to the funding of transit in this community. So make sure you let your legislators know that public transit investment is a key to moving the state forward and the region forward. I want to thank you all for your time today. This will be available on our website. If you're not a member of Citizens for Modern Transit, please consider joining us this year as we take on these really important conversations. Make it a great day, and thank you.